We are live.
Good evening, everyone. I welcome you all to iFocus Online. Today, we are having the lecture number 14 under the Refractive Surgery module of iFocus Online on the topic Photoablation, Fundamentals of an Excimer Laser Correction, Calculations of Ablation Depth, and PTA, which will be presented by Dr. Ritika Mukherji. So, I would like to introduce you all to the moderator for today, Dr. Karan Bhatia. Sir is a cornea, cataract, anterior segment, and refractive surgeon. He did his DNB from Arvind Eye Hospital, Puducherry, and Sir did his fellowship in cornea, phacoemulsification, and refractive surgery from Joshi Eye Institute, Hubli, Karnataka. Sir is well trained in corneal lamellar surgeries under Dr. Rajesh Fogla, and he's also trained in pediatric cornea by Sight Life. Sir did his Crocs course at Narayana Nitralaya, Bangalore, and observership at Regional Eye Center, USA. Sir has received multiple awards at various conferences and AAO, AIOC, Delhi Film Festival, COSCON, and many others. He's developed the MYX technique of SFIOL implantation, and Sir has participated in various national and international conferences. We welcome you, sir. I would also like to introduce our chairperson for tonight, Dr. Shalini Sharma. Ma'am is a senior consultant in cataract and refractive surgery at Eye Hospital in Noida. Ma'am did her MS in ophthalmology from NSCB Medical College, Jabalpur. Previously worked at St. Stephen's Hospital and Shroff Eye Hospital in Delhi. Ma'am has an experience in training refractive surgeons at New Vision Eye Center, Vadodara, and she is actively involved in teaching and training of various national and international trainees at eye care and has over hundreds of trainee doctors under her, which she has trained under her supervision. Ma'am has also been an integral part of Alcon FACO development program at iCare, and she's been a guide and co-guide for several postgraduate thesis students. Ma'am has been actively involved in organizing workshops for practitioners for skill enhancement. Lastly, I would like to introduce our speaker for tonight, Dr. Ritica Mukherji. She did her MBBS in 2016 from Rohilkhand University in Uttar Pradesh and MS in ophthalmology in 2021 from Jawaharlal Nehru Medical College, Wardha, Maharashtra. She has done her fellowship in cataract and refractive surgery from Narayana Nitralaya, Bangalore, and she is a ratified member of AIOS and DOS. She has published various articles in national and international journals, and she has won Best Poster at International CXL Meet held in December at Zurich, Switzerland, and Best Poster at ESCRS in Vienna. She's also received the Siva Hardy Award for Best Paper in Refractive Surgery and has Best Papers in Innovations and Refractive Surgery held in IISI Delhi in 2023. So over to you, Dr. Ritika.
Thank you, Dr. Navneet. I'll just share my slides. Okay, so good evening, everyone. Today's topic is photoablation. We'll be talking about the fundamentals of an excimer laser correction, calculation of ablation depth, and percentage tissue altered. So these are the headings that we'll be discussing under. So starting with the fundamentals of an excimer laser correction. So lasers can be classified on the basis of the wavelength of light emitted by them. They can also be classified on the basis of the active media which is creating the laser. So based on this, the laser may be a solid state laser, gas state laser, metal vapors or dyes, which are less common, excimer lasers and diode lasers. So we'll be focusing on excimer laser. It is based on the combination of two gases, a noble gas and a halogen. And the term excimer itself is derived from a contraction of excited dimer. So both of these gases are generally in a normal low energy state. But when a electrical discharge is applied in a laser cavity that contains these gases, they combine to form a higher energy gas state compound, and that emits the laser light. So the commonly used gases for excimer lasers are argon fluoride, krypton fluoride, and krypton chloride. So what in general happens is the light which is there in the visible range that results in a photocoagulation effect, but the lasers which emit an ultraviolet result in a photoablation, and those in the infrared range of light cause photodisruption or photocoagulation. So, argon fluoride with a wavelength of 193 nanometers actually falls in the ultraviolet C range of the light spectrum. And this is why the major effect that this laser has is a photoablation. Other lasers like Nd:YAG, which is used in the posterior capsulotomy, causes a photo disruption effect and it falls in the infrared range of the visible spectrum. So, what happens when a laser interacts with a tissue? The reaction which we can see on any tissue can either be a thermal effect, a photochemical effect, or an ionizing effect. Thermal effect usually occurs because of heat generation, so that can either cause coagulation, disruption of the tissue, or vaporization of the tissue. These thermal effects have already been discussed in a previous iFocus lecture this month. I'll be focusing mainly on photoablation. So, photoablation is also known as cold ablation. In this, there is direct dissociation of the bonds, and more important point to note is that there is no generation of heat. That is why it's called a cold ablation. So, the 193 nanometer wavelength of the Excimer laser actually has a higher energy than the molecular bond which is seen in the proteins, glycosaminoglycans, and nucleic acids which are present in the cornea. Therefore, whenever the laser is absorbed into the corneal tissue, it ends up breaking the bonds. So when that happens, there are fragments of the molecular tissue which are released and ejected from the cornea at very high speeds at the rate of 10 to the power 7 to 10 to the power 9. And then this ablated material appears as an effluent plume which is not really visible to the human eye, giving rise to a micro hole which is created. So that is how the photoablation works. The advantage of using an argon fluoride laser is that it causes very few deep direct hits, as in the shock wave generated is very less. The ablation process is very rapid, and the excess energy is removed in the form of the plume that we discussed. Because it is removed so effectively and fast, there is minimal heat damage to the surrounding tissues, and the photoablative effect in general does not cause any coagulation unless it is of a higher wavelength of light. So argon fluoride does not cause any coagulation effect. So this is what makes it ideal to be utilized in a tissue like the cornea, which does not have any blood vessels and is especially useful for sculpting the cornea, which is what we need for a corneal refractive surgery. So, just a brief history of how excimer laser came to be used in refractive surgery. As early as 1981, the first observation was made that the ultra short UV light has an effect on the cornea, and this was attributed to a civilian contractor, Mr. John Taboda, who was actually studying the laser toxicity in the military. At around the same time in around 1983, there was this photochemist called R. Srinivasan who was developing microchips at IBM, and they were using the Excimer laser made with argon fluoride to design those chips and basically make very small size chips. And they were the first to actually demonstrate the effect of photoablation on human hair, turkey, and other such things. So this was noticed by Dr. Stephen Trokel, and he utilized the argon fluoride laser available at IBM in order to use it on the cornea. His initial work was done on animal models and non-sighted human eyes, and he, along with Professor John Marshall, actually introduced the photorefractive keratectomy, but this was done in the non-sighted eyes. At around 1988, Margaret MacDonald was the first one who performed a PRK on a first sighted human eye, and over the next 10 years, this technology was further developed. In 1989, Professor John Marshall patented the use of excimer laser to reshape the cornea. And in around 1990, there was also development of the LASIK procedure, which also utilized the excimer. So these things were happening at the same time. So whenever we are talking about an excimer laser, there are few parameters that we need to consider in order to understand the effect that it has on the corneal tissue. First being the wavelength of light which is emitted. Depending on the dimer which is used to create the laser, the wavelength differs. So argon fluoride, which is the most commonly used, has a wavelength of 193 nanometers, and krypton fluoride has a slightly higher wavelength at 248 nanometers. We also need to talk about the power, also known as the fluence. That is the laser energy which is measured in terms of millijoules per centimeter square. The spot size is decided by the laser beam, and there has been very many technological advancements in this. The earliest spot size was determined by the broad beam laser, which was a single homogenized beam of light. The flying spot delivery came later, followed by the variable spot scanning. We'll be discussing this in detail in a bit. And the duration of laser also is important in terms of heat generation and the correction which occurs. And this also depends on the pulse rate or the frequency, that is the rate at which the pulses are delivered on the cornea. So, coming to the wavelength, the krypton fluoride has a predominant photoablative effect, but as I had discussed, it is a slightly higher wavelength, so it can cause a little bit of photocoagulation also, which we do not want on the corneal surface. So, argon fluoride is usually the preferred choice. Coming to the power or the fluence, the fluence range appropriate for ophthalmic applications lies between 120 to 180 millijoules per centimeter square. This is the safe range of fluence which can be applied on the cornea. And the amount of energy or fluence delivered on the cornea actually depends on the excimer laser beam profile. So there are various beam profiles which have been discussed based on the intensity of the light. Just a second. Intensity of the fluence distribution. So the main three beam profiles are Gaussian, homogeneous, and reverse Gaussian. Homogeneous or the flat beam profile. So as we can see here, the amount of fluence or energy delivered at each point of the laser beam is equal, which is why it's called homogeneous. A Gaussian beam profile has a slight slope to it. This is because in the center, the fluence delivered is the maximum. That is, the amount of energy delivered in the center of this beam is maximum. And as we go to the sides, the amount of energy delivered reduces. The reverse Gaussian is the exact opposite of the Gaussian beam profile. Here, the periphery has the maximum amount of energy delivered, whereas the center has lower amounts of energy. So what we see here is a single laser spot. This is not how the laser is fired on the cornea. This is just a single laser spot, and multiple laser spots is what actually corrects the power on the cornea. So a single laser spot will again have more energy in the center as compared to the periphery when we're talking about a Gaussian beam profile. So this determines how much power is delivered. Coming to the spot size, so the earliest beam which was developed was the broad beam. So it just had a very large diameter, and a lot of the laser spots were delivered simultaneously in the same fashion. So obviously, because we are delivering a lot of laser spots at the same time, the treatment was faster for that given frequency. Sorry. The treatment was faster, and it was less sensitive to decentration because the treatment time was smaller, so patients were not moving their head very frequently. But it is a less homogenized beam because there are a lot of spots closely bound together. And if it is say a homogenized or a flat beam profile like we discussed, there will be irregular spots because the energy is not distributed equally. So that is why the thermal effect or damage to the cornea because of the shock waves was slightly higher in a broad beam delivery system. And we also needed to use masks like this in order to decide where we want the beam to be placed. So for a astigmatism, they had to place beams and then move it to the center so that the laser was only fired in the periphery and not in the center in order to correct the astigmatism. And for a myopia correction, we had to use masks like this so that the beam was only fired in the center and not in the periphery, so that we could have a central flattening. So this is why it is not possible to perform customized treatments or treatments on irregular corneas using a broad beam delivery system. This is why we came up with the flying spot delivery system. So it converts the laser beam into multiple small round spots, which can range from a size of 0.6 to 2 millimeters. And this has the most homogenized part of the beam is used, and it is reflected onto the desired area of the cornea by using rotating mirrors. And in this, a very high frequency is needed so that we can shorten the treatment period. Otherwise, changing the direction and then firing in a specific spot would actually take a lot of time. That is why a very high frequency of pulses need to be delivered, and we need to have a precise distribution of the spot so that there is no thermal effect. This is why these systems required the necessity for a eye tracking system. That is how the eye tracking systems in all the LASIK machines came up, because we needed to be fast, and because the delivery had to be very precise, we needed an eye tracking system. And this is also the reason why this sort of laser delivery is very sensitive to decentration, because it takes time. So the energy profile of each spot is Gaussian. So more energy is delivered at the center of each spot as compared to the periphery. And this results in a smoother ablation because the distance between each spot is kept at a size of half the beam size. So the distance, as you can see here, half the beam size, so that there is a regular ablation and no spots are missed. And the center of each spot has the maximum energy delivered. So this again ensured that there is a smoother ablation. The main advantage of these systems was that we were able to treat a high level of irregularities while still maintaining an aspheric profile. Because the laser spot size is so small, we can move it anywhere we want, and we can use it to treat even very irregular corneas. Coming to the duration, that depends on basically the breakup time of the excited dimer or the argon fluoride laser. So the pulse arises only when the dimer is in the highly unstable state, the breakup time for which is around 9 to 23 nanoseconds. So that is why the actual pulse lasts for around 10 to 20 nanoseconds, depending on which laser is used. And shorter the pulses, less effect it has on the corneal surface in terms of thermal heat generation. And pulse frequency is the number of pulses which is emitted per second. So this can range from 10 to 1050 hertz. So the numbers that we see on the machines like EX500 and Schwinn-Damaris 1050, this actually is the pulse frequency. So Excimer 500 has a pulse frequency of 500. It will deliver approximately a frequency of 500 hertz. And Schwinn has 1050, which is the highest. So higher the frequency, the treatment is definitely faster because we are delivering more pulses per second. But obviously the thermal effect will also be higher. So all these machines require a algorithm which cools down the treated tissue so that it does not cause overcorrection. These algorithms are actually patented, so companies don't really tell us how they have managed to cool it down at that rate. But there are systems in place to ensure that there is no overheating or overcorrection. And the speed also depends on the success of the algorithm in positioning the next subsequent strike. Because if we are going very fast, we need the next strike to come precisely where we want it to. So it is the company algorithm which decides that. These are the various companies which have come up with Excimer lasers. And as you can see, most of them have the flying spot laser delivery system, except the Nidec, which is still using a scanning slit system. The beam profile is Gaussian for mostly all of them, with certain differences like a truncated Gaussian profile or an ultra thin Gaussian profile, which is used in wavelight. Companies have not really revealed how it is different from the main Gaussian profile. However, we can assume that it is just a smaller spot size. They are working on making the spot sizes smaller so that there is more uh, number of spots which can be covered. That's how the Contura machine works. The spot sizes are really smaller, so it's able to measure and treat a large number of spots. The spot size is smallest for the Schwinn-Damaris, and we can see the pulse frequency here. So it's 500 for Wavelight as well as Technolas. Schwinn-Damaris works at a frequency of 1050. For MEL 90, PRK is done at a frequency of 250, and the LASIK procedure is done at a frequency of 500. As discussed, all these are using the flying spot laser system, so they all need a eye tracking system. And these are again patented technologies, the details of which are not available very readily to us. So there are certain other variables that we need to understand how the excimer laser correction works. First is the constant energy of radiation on a measured area. What this means is when a laser hits the cornea, it has to reach a certain fluence before any photoablative effect can be seen. And that value for the argon fluoride laser that has a wavelength of 193 nanometers is 50 millijoules. So if we don't reach an energy of 50 millijoules on the cornea, there will be no photoablation. It will be an irregular or incomplete photoablation, and each pulse which has a fluence above this threshold will remove a precise amount of tissue. And the amount of tissue removed is not linear. It is some if say about 100 millijoules of energy will remove 2 microns of stroma, then 150 will not automatically reduce 4. It is not a linear removal of tissue because of the fluence delivered. And this can go up to a maximum value of 600 millijoules. The safe value is 120 to 180 millijoules, which we discussed previously, but 600 is the maximum. Even if the energy goes above 600, there will no longer be a photoablative effect. So 50 to 600 is where the photoablative uh, mechanism works for a laser with a wavelight of 193 nanojoules. Coming to the degree of ablation, this is the amount of ablation rate that occurs per impact. So 0.25 to zero point 0.6 microns is how much the machine will ablate as soon as it hits, but there are certain factors which affect this value. For example, the different histologic layers of the cornea behave differently. The epithelium ablates more rapidly than the stroma, which again ablates almost 30% more rapidly than the Bowman's layer. And the corneal scars, if they are present, they will ablate less rapidly, obviously, because there is more collagen deposition there. And the ablation rate is also impacted by the corneal hydration status. So if the cornea is very dry, then it can cause more ablation, and if it is slightly hydrated, it can cause less ablation, leading to under or overcorrection of up to 10 to 15%. This is why whenever we're doing a LASIK, we have to ensure that we are drying the cornea before we start firing the laser, because the ablation rate changes. Coming to the computer controls, a computer controls the laser's key parameters, especially fluence, because whenever there is degradation of the gaseous mixture, it identifies it and releases an electrical discharge so that the laser can keep firing. It also helps us choose the mode that we want to treat in, whether we want to do a refractive correction or a PTK, say for a scar removal. It also helps choose the ablation profile based on the refraction, helps us to change the optical and the transition zones. And for custom ablation profile, it also integrates the corneal topography and wavefront data so that we can calculate the residual stromal bed and ablation profile accordingly. So we keep saying that the excimer laser will have a thermal effect. If the pulse rate is high, there will be heat generation. But we have established that photoablation is actually a cold ablation and there should not be any heat generation. So what is this thermal effect? It is basically generated by the recoil of the photoablated matter. When this photoablated material from the cornea is released, it causes an acoustic wave, and that causes a thermal effect, and the amplitude of the shock wave gradually decreases. So it's not an actual heat generation, it is just a thermal effect due to the acoustic wave generation. Coming to the calculation of ablation depths for refractive surgery, for this we need to know certain basic rules and laws. The oldest one of which is the Barreker's thickness law, which states that whenever a tissue is either added to the periphery of the cornea or removed from the central part, it causes a corresponding flattening, and vice versa. And whenever tissue is added to the center or removed from the periphery, it results in an increase in curvature. So a corresponding flattening will result in a hyperopic refractive shift, whereas an increase in curvature will result in a myopic power shift. So these laws form the basis of keratomiliosis for refractive correction and were first described by Barreker in 1980. Coming to the Munerlin approximated formula, so this is used to calculate the ablation depth using the Barreker's law. Why do I say approximated formula? Because the actual formula which was first described actually considered three parameters. That is the pre-surgery radius of curvature, the post-surgery radius of curvature, the chord length, which gave us the optical zone diameter, and S1 and S2, which is the sagittal depth of the preoperative and postoperative cornea. That is the distance from the surface of the cornea up till the chord length, which is derived from the optical zone. So it considered the optical zone, the pre and final radius of curvature, as well as the depth of ablation. So that is how we calculate the ablation depth. But in the approximated formula, which is commonly used, there is no mention of the radius of curvature. Whenever we are calculating, suppose we need to correct 6 diopters of myopia with a optical zone of 6 mm, the ablation depth would be calculated by Munerlin approximated formula as 72 microns. However, there were certain assumptions in the Munerlin formula which make it not very accurate, because it assumes that the anterior surface of the cornea is a perfect sphere. This is why initially the radius of curvature was included in the formula but later removed. And also it considers that ablation depth is just a distance from the optical axis. It is a function of the distance from the optical axis. But that is not always the case, because in case of a decentered ablation or say a larger zone, it will not be bang on in the center. It also assumes that optical zone would be 5 millimeter, because at the time that this formula was generated, they did not think that we would be treating very, very high refractive errors. So he made the assumption of the maximum optical zone being 5 millimeters. And it also, this is the reason it underestimates the ablation depth. So modification for this, which was given by Chang et al., is that we should use the Munerlin exact formula, which takes into account the radius of curvature. However, it is very difficult to in real time to calculate the radius of curvature. What we use is a very simplified version of it in order to calculate the ablation depth. So we use 14 microns per diopter. We consider 14 microns per diopter of ablation for an optical zone of 6.5. And if the optical zone is kept at 6, we consider the ablation depth to be 12 micron per diopter. So this is the table given by most Excimer laser platforms. So you can see they give the ablation depth for different optical zones which are commonly used. So for a 6 millimeter optical zone, if we are to correct one diopter, the approximate ablation depth is 12. So let's look at an example to understand this. Suppose we have to correct a refractive error of minus 7.5 diopters with a cylinder of minus 1 at 180 and a 550 micron corneal thickness, where the pupil size in mesopic conditions is 5.5. So the ablation zone is always kept slightly larger than the dilated pupil. So in this case, we will keep it as say 6 millimeters. So how do we calculate the ablation depth? We will multiply the spherical correction with 12, which is what we discussed. Now for cylindrical corrections, we should try to keep a higher ablation depth, because it is going to correct the cylinder at the periphery. So this is a with the rule astigmatism. So it is going to fire the laser on the periphery in order to flatten it. So that is why we should we should consider the same ablation depth that we would consider for a 6.5 optical zone. So we've kept 14 here. And so that it comes out to be 104 microns. So if we consider a flap depth or a cap depth of say 110, the RSB calculation becomes 336. In case of a lenticular procedure, we take the cap depth instead of the flap depth. Coming to the residual stromal bed, the US FDA recommended RSB for a refractive procedure is at least 250 microns. This 250 microns of untouched cornea is important because it preserves the integrity, or in other words, the biomechanical strength of the cornea, so that we don't develop ectasia later on. So the calculation that is usually done to calculate it is we subtract the ablation depth as well as the flap thickness or the cap depth from the central corneal thickness. Some surgeons choose to keep a more strict RSB cutoff. They will not go beyond 300 microns as an extra precaution, but ectasia has still been reported in cases where 300 microns was kept as an RSB. So it is not a direct risk factor, but an indirect risk factor. This is why we needed to develop a better indicator, and that is how the percentage tissue altered came into the picture. So it was first described by Santiago et al. And the basic reasoning was that it is the anterior 40% of the corneal stroma which offers the greatest biomechanical strength to the cornea, because the lamellae are more closely bound over there. And this is what is fundamentally altered in laser refractive surgery. So if we are able to keep this value less than 0.4 or 40%, we would be preserving the integrity or the biomechanical strength of the cornea. So the equation given by Santiago et al. Was for LASIK flap thickness plus ablation depth divided by the central corneal thickness. For PRK epithelium thickness, that is the thickness of the epithelium which is removed, whether or not we can measure it directly. Mostly in the clinic setting, we use say 50 to 60 microns as the epithelial thickness. And divided by the central corneal thickness. For SMILE, we take the cap thickness plus lenticule thickness divided by the central corneal thickness. So whenever the thinnest corneal thickness is available, we should consider that instead of the central corneal thickness so that we have the lowest value of the PTA that we can get. So a PTA of less than 0.4 has the lowest risk of ectasia, but if a PTA is higher than zero point 0.4, there is a high risk of ectasia. And other things which Santiago described was that a high PT at the time of LASIK is consistently associated with development of ectasia. So he suggested that if your PTA is higher than 40%, the patient will develop ectasia without any doubt. However, that is not the case. We have seen certain patients who have a PT of 40 or maybe borderline 40, 41 have not developed ectasia. So there are other points that also need to be considered. It is a more robust indicator than RSB and central corneal thickness for sure, because it is considering the flap thickness it is taking the flap thickness into consideration. Thicker flaps alone do not create ectasia unless we are correcting a very high power. So a greater ablation depth is there. So there is more biomechanical instability. And he also suggested that there is a significant correlation between the PTA and risk of ectasia in eyes with a suspicious corneal topography. However, we would not do a LASIK in an eye which has a suspicious corneal topography. So these were a few drawbacks of this PTA that was initially described. Also, they stated that there is no safe limit for PTA if the topography or tomography is abnormal. So, does PTA work? There have been a number of studies which have been published after the PTA was described. One such study by Hongxing Ong suggested that there is an inconsistency of flaps, especially those made by microkeratome versus those made by femtosecond laser. There is a standard deviation in the thickness of the flaps ranging from 12.4 microns to 24 microns when done with microkeratomes. And even with femtosecond lasers, there is a slight variation in the range from 5.6 microns to 16 microns. So whenever the flap thickness is altered, in real time, it can affect the actual ablation depth and therefore invalidate the calculated PTA which we have calculated initially. So when you are starting out surgery, sometimes we may get an invariably thick flap using microkeratome. In these cases, the PTA which you have calculated preoperatively will no longer hold true. Saad et al. Has described, he used PTA in a large group of patients, approximately 300 patients, and he mentioned that the PTA that was initially calculated was only done on placebo-based topographers. So whatever central corneal thickness values were taken, ablation depth was calculated, it was done on the basis of the placebo-based topographers. So they might not have detected form thrust keratoconus in those individuals or any subclinical KC. So nowadays we are obviously using the Scheimpflug based topography. So a difference in the placebo measurements versus the new topography or tomography that are in the market may also alter the PTA. And in this study, they did not find that the PTA was able to detect ectasia in any of the patients that they had calculated the PTA for. And in this study, they had used multiple topographers, not just placebo-based topographers, thereby invalidating the original study. Sir has also conducted a study on an Indian population, and he found that when we use the modified PTA alone as an indicator for LASIK, post-LASIK ectasia, uh, it was not significant, and he did not find any eyes that developed ectasia when we considered the PTA calculation. So it may not hold true for all races as well, because the initial study was done only on Caucasian eyes, and it may not hold true for Indian eyes. So we need to see other modified formulas, and we need to consider factors like age, race, or gender when determining the risk of ectasia. What about PTA in CLEX procedures? Since we are moving towards the age of lenticule extraction procedures, is there any way to calculate the PTA for these? So currently we are using the modified Santiago PTA only, wherein we are substituting the ablation depth with the cap thickness, cap thickness and the lenticule thickness uh, with the ablation depth, and we are dividing it by the central corneal thickness. So from a conceptual point of view, the amount of tissue that is altered in SMILE will be less as compared to LASIK, but we still have seen approximately 4 to 5 cases of SMILE ectasia which have been reported in literature, and they were discussed in this article which I have mentioned here. So what they found was that the RSB was above board for all the eyes. So there were around 4 patients, so 8 eyes, and they found that the RSB was above normal and all, and the PTA was also surprisingly normal except for 1 patient. So it may not be a very good indicator in cases of SMILE. And we need to develop an accurate calculation of PTA using data from patients who have developed ectasia after SMILE, which are not many in number, which is probably why we've not been able to do it till now. There are other factors which we need to consider apart from the ablation depth, residual thickness, and PTA. Primarily the flap thickness. Now, microkeratomes give us an average thickness of say 120 microns, but with femtosecond, we are able to make more precise flaps. We are able to make thinner, more predictable flaps, ranging from 100 to 120 microns, even 90 microns. So, a thinner flap can help preserve tissue where the RSB or the PTA is unfavorable, because obviously if there's a thinner flap, the RSB will be higher. Optical zone is another thing which we can decrease in order to preserve tissues, especially in cases where we need to do a higher correction. But of course, reducing the optical zone will cause greater photic phenomena, especially in patients who have larger pupil size in mesopic conditions. The more advanced wavefront guided and wavefront optimized ablations offer a blend zone, which typically extends 2 millimeters beyond the actual optical zone. So again, the algorithms of the laser is such that they will fire lesser fluence in the blend zone as compared to the main optical zone, and that is what creates the blend zone. The fluence delivered in the blend zone is lower, so they will basically direct the flying laser spot in such a way that there is lesser energy delivered in the periphery of the optical zone, creating a sort of blend. We also need to consider changes in the keratometry values after LASIK. So in general, the K1 flattens or reduces by 0.8 diopters uh, for correction of each diopter of myopia which is treated, and K2 steepens or increases by 1 diopter for each diopter of hyperopia which is treated. So for a myopic ablation, the flat SIM-K should not go beyond 34 diopters after we have corrected it. And for a hyperopic ablation, the Kmax should not be more than 49 diopters. And this we can calculate preoperatively. So for example, if we have a patient who needs to undergo a myopic correction of -2 diopter spherical error, and has a flat SIM-K of 42 diopters, the reduction in K value which can be calculated is 2 into 0.8, which is around 1.6 diopters. And so the K value after correction would be 40.4, which is well within the range. The range being that for a myopic ablation, the flat SIM-K should not go should not go below 34 diopters, and for a hyperopic ablation, the Kmax should not be more than 49 diopters. The reason for this is in say a myopic ablation, there will the peripheral part of the cornea, there is excessive flattening in the center, so the rays which are falling on the peripheral part will focus in front as compared to the central rays and give rise to a positive spherical aberration. And the exact opposite will happen for a hyperopic ablation, wherein the central rays will focus in front, giving rise to a negative spherical aberration, giving rise to a lot of glare and halos for the patient. Some other less important factors to consider are corneal hydration and transparency. Like we discussed earlier, the corneal scars ablate less rapidly than healthy tissues, and the ablation rate is also affected by the corneal dehydration status. So it is impossible to measure the corneal dehydration. There is one such study where they have tried to measure corneal dehydration using an online optical coherence pachymetry. So they are basically seeing the corneal thickness while exposing it to dehydration factors. So they suggested that during a laser ablation, there is increase in temperature, generation of shock waves. So this can impact the corneal thickness, and maybe in the future we can measure the dehydration status intraoperatively during a refractive procedure using it. But till now, it has not been done. And humidity and ambient temperature are other factors. So OTs are usually temperature and humidity controlled, especially refractive OTs. And multiple studies have been conducted to assess whether or not it has any effect on the corneal hydration and the firing of the laser. But most of the studies which I found were inconclusive, and they said that there was no statistical significance between change in the humidity and ambient temperature versus the correction after LASIK. Randleman ectasia risk scoring is another scoring system which is used to predict ectasia postoperatively. It was described by Randleman and all. And what he suggested was a score of 0 to 4 depending on these factors. So he considered the topography factor ranging from normal to form thrust, including abnormal topography, giving a score of 3 for inferior steepening and 4 for form thrust keratoconus. They also considered the residual stromal bed thickness and gave these values. And a controversial thing which they included was the age. They said that if the patient was more than 30 years, there was the score to be given was 0. And then there were di- different groups of patients less than 30 years of age, and they were all given an increasing score, suggesting that the younger the patient, higher the risk of ectasia. Corneal thickness and manifest refraction was also considered. Patients who had a score of 0 to 2 were considered low risk. Those with 3 points were considered moderate risk. 4 or more were classified as high risk. And the maximum score that could be given was 10 points. But there is a problem with this because they found that the odds ratio for ages more than 30 was very high. Maybe because there is a natural stiffening effect post that age, so therefore there is a lesser risk. But the age categories given below 30 years of age was very arbitrarily defined, and they've not given any explanation as to why they chose 18 to 21, 22 to 25, and so on. Also, not all patients who developed ectasia were picked up by the scoring system, even in their original study. It could be because, like we discussed earlier, unexpectedly thick unmeasured flaps due to microkeratome, limitations of placebo-based imaging, and other corneal biomechanical factors which were not discovered. Also, in the original study, they did not apply it to eyes undergoing surface ablation or lenticular procedures because there weren't any ectasia which happened in such patients at that time. In the study which I discussed earlier, where they reviewed the patients who developed ectasia after a smile surgery, they found that the Randleman ectasia risk score was actually higher in 5 of the eyes, with 3 eyes being classified with 5 eyes being classified as high risk and 3 eyes being identified as low risk out of the 8. So, in conclusion, maybe the Randleman ectasia score would be a better indicator of post smile ectasia as compared to the PTA, because the PTA did not identify any eye in this study at least. Of course, we need a larger sample study to validate this results, but the current study states that the Randleman ectasia was a better indicator for smile as compared to PTA. So the main drawbacks were, of course, the age categories. There is no data cited in literature where the relative ectasia risk is higher in younger patients. So this actually would have excluded a lot of the age groups which actually come to us for refractive surgery, because usually those are the patients who are asking for a refractive surgery. So we cannot not offer them surgery because we consider age as a risk factor, as this scoring would suggest. Also, the variability in flap thickness was a problem because we were not measuring the flaps intra-op to see whether or not they were actually as thick as we were calculating prior to the surgery. So what does the future hold? What we need to do is include biomechanical strength, because ultimately the risk of ectasia is directly proportional to how weak we are making the cornea after a refractive surgery. So one such study which used the in vivo prediction of air puffed induced corneal deformation. So what they did was they created a finite element model to mimic a refractive surgery, say LASIK, SMILE, or PRK, and then they compared the Corvus values, Pentacam values from pre-operative to the post-operative and tried to create a model of the surgery and individualize it for each patient. So suppose they took data from the Pentacam and the Corvus from a patient. They created a model of refractive surgery, say LASIK, SMILE, or PRK, and then they saw how this cornea would react after this surgery in terms of the biomechanical strength. This was a initial preclinical study, but now they've also developed a software for this. It's not freely available, but the software tested retrospectively on a large cohort of LASIK, PRK, and SMILE eyes has found that it does accurately predict ectasia in such eyes. Um, there are other studies also which have established that biomechanical parameters like CBI and TBI would be a better indicator of ectasia susceptibility. So, a biomechanical evaluation, whenever possible, using a Corvus ST is a must in order to understand whether or not the patient may develop ectasia. So, to summarize, whenever we are trying to assess ectasia risk, we should see a combination of risk factors and not a single value. We should look for suspicious topography. Now that Scheimpflug topographies are available, we should also look for formfrust keratoconus, subclinical keratoconus, because those have the highest risk of developing ectasia. We can consider the age of the patient since it has been described in literature. Abnormal biomechanical indices should be looked at. We should calculate the PTA, the ectasia risk score. We should calculate the keratometry change as well as the refractive error to be corrected. Calculation of the PTA for higher refractive errors, we can consider decreasing the optical zone or the flap thickness to save tissue, but the risk of glare should be considered. And for CLEX procedures, PTN may not be very reliable, so a Randleman ectasia risk score might be a better indicator. However, this requires further testing. And there is a need to develop new risk scoring systems which include the preoperative corneal biomechanics and are better suited for Indian eyes. Thank you. Are there any questions?
So excellent presentation, Ritika. It was really a getting back to the basics, and I'm sure everybody would have learned a lot from this, and whoever has forgotten them also will like this lecture so much and remember it. So first of all, we welcome our chairman, Dr. Shalini ma'am, to this. So welcome, ma'am, to this program. And first of all, we'll start off with any comments from you, ma'am.
Yeah, good evening, everyone. I was a little late, and I'm really happy to be part of this platform. Excellent presentation, Ritika. It was very, very nice. I have never, in one sitting, everything in one go is absolutely crystal clear. And beautifully, you have explained how LASIK machines and how the thing has evolved in all these years. So, very nice presentation, Ritika.
Thank you, ma'am.
So I have a couple of questions. So first of all, I'll clear one thing. So you had asked me regarding the PTA that we had. So even
Yes.
we found out, as discussed with Saad, as by the paper of Saad Eatle, was that Santiago had used placido-based topography. So the screening was the basic problem, because of which we believed that PTA is not a reliable indicator. And apart from, we considered the TCT, so that was why the modified PTA came into account rather than the CCT that was taken by Santiago. And the TCT is a better indicator than the CCT. So a couple of questions that I have is, so when we talk about topo guided PRK, so how
Yes.
does it work? How does it counter the HOAs that are there associated with the eye?
Right. So, what happens is we are trying to maintain the aspheric profile. The reason that the patients are developing an HOA is because when we are firing the laser, we are from our side inducing certain HOAs. Like I explained, we are flattening the center, so there are peripheral the periphery becomes more steep, and so there is a generation of say a positive SA, especially after a myopic correction. So what the laser does is it additionally fires on the periphery without correcting too much of a power. So it will fire on the periphery even for a myopic ablation in order to maintain that asphericity. So that is how it makes sure that we do not induce more astigmatism while correcting.
Follow up to this question, and I'm sure both of us or none of us have any financial interest to this. So the different laser platforms are different. So the Zeiss platform is very different from the Schwinn to the Alcon platform to
Yes.
the Nidec platform. So considering this, see, there are some systems which allow you to customizely treat, particularly when you're dealing with keratoconic eyes or some eyes with
Yes.
HOA. So can you
Right.
give a a short summary or some
Yes.
points regarding that?
So, in the Alcon platform, Excimer platform, they let us see the HOA, they let us see the value of the HOA, which has been measured using the topolizer, but we cannot alter it. However, in the Schwinn platform, there is an option of switching on or switching off the higher order aberrations. So, in the Schwinn, particularly, customized treatments are better because if we have a very highly irregular cornea, if we are planning a TCAT or a customized ablation for an irregular cornea or say a post RK case, in those cases we can select and choose which HOA to treat and which HOA to not treat. Those are the two main ones that I have worked with. I'm not sure whether this is possible in NIDEC. I don't think they have that option in that.
They do not have that option as far as
Mm.
I'm concerned, but Dr. Raja did come up with an algorithm.
Okay.
It was called the Bharat protocol by which he is
Yes.
working on.
Yes.
With the
Yes.
Zeiss, I don't think customization is anything you can do. Topochiral treatments are not there in Zeiss. So again, we'll
Yes.
say that we do not have any financial interest. This is just for academics only. I'll go back to the lasers now. So a couple of questions regarding PTK. So, what are your suggestions for people who are doing PTK, particularly for corneal scars, and how do you change the profile and how much, when should you go for it?
Right. So I think on the Alcon platform, EX500, it's not possible to pick and choose where we want. If it is a diffuse, generalized scar, maybe a 50 micron PTK in a 5 or 6 zone, if it's in the visual axis, that would be the way to go. However, if it is a peripheral scar, then I don't think EX500 would be a good option for that because there is no way to shift your optical zone. There is no way to choose where you want to treat. This is possible on the Schwinn Damaris software because you can use the PTK mode in that, and in that you can actually select the X and Y coordinates of the optical zone. So you can pick and choose where you want the laser to fire, and in that it is possible to treat even the peripheral scars using the PTK.
Absolutely. In cases of Salzman layer degeneration also, but that time you have to just do a PTK, superficial
Yes,
keratectomy, and then do a
keratectomy.
PTK, regularizes the surface. And the patients also do pretty well with contact lenses post that. So, any questions from you, ma'am? Any questions?
No, Ritika.
Okay, so I have another question now.
Yeah.
So how, so one of the things that as refractive surgeons dread about is seeing mebum, when it come on the operating table, the secretions
Yes,
from the meibomian gland. So
yes,
how does that change the, ablation process, and why should you
right.
treat MGD before and dry eyes before taking up the patient for refractive surgery?
Right. So, theoretically, mebum secretion will create an additional layer over the cornea. So, it is slightly increasing your corneal thickness. So, the laser ablation rate. So, like I explained, whenever there is something on your cornea, whether it is water, whether it is mebum, it will reduce the ablation rate. So, the amount of tissue ablated will be altered. Nobody's actually studied how much will be altered, but theoretically, yes, we will probably ablate at a lower rate, and so less tissue will be ablated and there are chances of an undercorrection. So definitely an MGD should be treated prior to refractive surgery. And if you notice that layer even intraoperatively while you are doing the washing, you should treat it postoperatively as well.
As the refractive surgeon, I think treating the MGD and dry eyes is absolutely one thing which should be very careful. We cannot give it that we have seen it on the table. This is like should be not all right for us. uh, Even the, as you said, that although the studies have been there that temperature and humidity has no impact, but I personally, as a practical thing, I think that if the cornea stromal bed is hydrated or too dry, even the humidity level, I have seen the cases going little bit here and there with the ablation. So even I can recall years back in my personal this thing experience, that once the OT for a longer time had the altered humidity and the this thing in the OT, and in a sequence we got many cases which were not showing the exact correction, and then we checked our register and we understood that what is happening actually. So that sebum is like anything from the mabuban gland definitely will have impact on the ablation, how much we are ablating.
Also,
Post-operatively, also there is inflammation in these eyes.
Yeah,
There is
absolutely.
some sort of, any questions, Navneet, from your side?
yes, there's a question from one of the residents. So, what all factors are to be considered in a patient with borderline PTA? Like you said, like some patients, they have been doing well after a borderline PTA. So, what all factors, additional factors are to be
Right.
considered?
So PTA is not the only thing that we should consider. In such cases, you should also see how much refractive error you're correcting. So a good way to assess is if you are correcting a spherical equivalent more than 6 and your PTA is borderline, avoid corneal refractive procedure, prefer phakic IOL. If your spherical equivalent is less than 6 and it is a borderline PTA, but the biomechanics, the TBI values are normal, then maybe you can consider a refractive procedure. If you feel that the cornea is also suspicious, then again avoid and go for a phakic IOL. But if you feel the topography is normal, then maybe you can consider it. You'll have to play it case by case and see. In some cases, you might feel that doing a extra procedure along with a refractive procedure would be better because the biomechanics are slightly borderline.
Yes. So basically,
I'll add to this question right now. So how does an extra procedure also causes some amount of flattening?
yeah.
So then how do you predict in such cases?
It's difficult to predict because we cannot obviously undercorrect the laser that we are firing, but definitely making sure that your duration of the extra procedure is on point. Maybe you can consider for very, because you will be doing this only for very higher refractive errors, say 8 or 9. So, anyways, you will probably be applying a nomogram. In those cases, try to undercorrect slightly and then do the extra procedure. But of course, nobody has really conducted a study on this. This is all hypothetical. Ideally, we'll be correcting the full power and doing extra for the recommended 3 minutes.
So
And
Navneet, can I pitch in a little bit for this? So for the person who had just asked this question, so the PTA or other things are not as important as your topography or tomography is. That is the most important indicator of whether you should do a refractive procedure or not. Now, as Ritika has said, the power of the ablation or the power of refractive error that you are treating is also of critical. Suppose you have an elevation, a slight elevation or borderline elevation, posterior elevation that you see on the bad display, but if the power is about -2, -2.5, then you can get away with a PRK procedure.
PRK.
PRK is the safest procedure for the cornea in comparison to LASIK and Smile or or Silk, whatever it is. But it has its limitations also. Scarring is there when you treat it with higher powers. Uh, there is this, you need to look at also whether there's any skewing at in the in the sagittal curvature map that you see. And any idea of an asymmetrical bow tie pattern is an indicator that this could be a case of from spastic keratoconus, even though everything else is fine. So you need to see these topographies, as he said, biomechanics, everything, RSB, amount of ablation you're doing, everything has to be taken into control, and then only you take a decision. If it's not a safe procedure, then the better way would be to go ahead with the phakic IOL. If
PKI.
that, not a CLE or an RLE. If not, nothing. That is better than,
better not to touch such
yes.
eyes.
So,
So
yeah,
there's
as
another.
Karan said, very this thing, ki we need not in practical day-to-day practice, we don't calculate PTA by formula, we don't sit down and calculate that way. You have to evaluate the refractive error with your topography and see how much you can fit in. Yeah, and PRK is the best option in anywhere it's doubt. Either you go for PRK, or if in the higher number, go for ICL. Don't try to fit in the procedure on the borderline cases. That is the thumb rule for me.
And also, like Dr. Ritika mentioned about the extra procedures, there have been many studies wherein patients were like had haze in the interface later on. So I think that is a little troublesome for long-term cases in patients with higher refractive errors. So it's better that we either like go in for ICL procedure or better not to touch such eyes.
PRK, yeah,
So there's
absolutely.
another question. Does ablation depth calculation vary for hyperopia as compared to myopia?
Not really, because even in the original study which they have described, they have not considered the signage. So for a hyperopic correction also, you will use the same formula. The difference occurs in the algorithm which the laser uses. So you don't have to worry about it. The laser will fire in the periphery only, even if you are calculating ablation depth by the same formula.
Yes.
So I will add to this, when you in hyperropes, when you are calculating for the ablation, even if it is a borderline case, where we in a myopic case, we might not try to go for the LASIK, but if it's a hyperopic case, we have to consider look into the peripheral thickness. Even if its thickness is borderline in the center, and by the cutoff formula, we are just trying to fit in the case. In hyperope, you can safely go for it
Go for it.
because we have
That's
nothing to
true,
do with
ma'am.
the central thickness.
Yes, that's a very good point.
So another student has asked, can you explain the concept of a flying spot, an adjustable spot size, and scanning slit?
Right. So, in scanning slit, again, they basically put a mask. Like I explained, in broad beam, we use diaphragms or masks in order to direct where we want the spot to be fired. So, in scanning slit, there was a permanent mask, you can say, which moved with the machine so that we could fire the laser in the desired area. As far as the flying spot is concerned, it is more flexible because there is a single beam which is firing at one point, and then the machine is also less bulky. The mirrors are helping us to rotate wherever we want it. So in a scanning slit, it is very difficult to position it exactly. So again, it is slightly better than broad beam in terms of irregular corneas, but again, flying spot is the best option because the size of the laser beam is very small. In both broad beam and scanning slit, the size of the beam is very large, so we cannot focus on very fine areas. Main difference is the size of the spot, which has to be small.
So
So
now mostly we are using the flying spot only.
Yes,
We are
yes, ma'am.
not using any other this
No.
thing.
So Nidec has the scanning slit technology. They are not using the flying spot.
Acha. Okay.
Yes.
Okay, right.
so that's all for the questions. Sir and ma'am, if you want to add anything else.
I'll ask one last question. If there was something you could do to change refractive surgery, what would that be?
Uh, I would figure out a protocol for when not to do surgery because every protocol that we have in refractive surgery is to how can we operate this patient. Every protocol which has been developed is working on how we can take in more risky patients, how we can operate on them. We should create a protocol which tells us that these are the patients that you don't have to operate on absolutely.
Yeah.
Thank
Navneet,
you.
anything else do we have?
No more questions, sir. Nothing else.
So, should we close the session then?
Yes, sir.
So, do you want to give the closing remarks?
So it was a very well and informative lecture by Dr. Ritika, and I would like to thank Dr. Shalini and Dr. Karan for their expert comments on the topic. So it was quite informative, and I hope and I am hopeful that the students they did gain some information and some new concepts in this topic.
Thank you.
Thank you, everyone.
Thank
Thank
you. Thank you.